Hello and welcome to our new topic that will focus on the pharmacological approach to primary headaches, particularly migraine, tension-type headache, and cluster headache. These conditions are common in clinical practice and require a thoughtful approach that balances efficacy, safety, and individualized therapy. We will explore drug choices, mechanisms, and when to escalate from symptomatic relief to preventive treatment. Let's start. The learning objectives are shown. By the end of this session, you should be able to describe the drug classes used to manage primary headaches, with emphasis on their mechanisms, receptor selectivity, and side effect profiles. You will also understand the clinical reasoning behind choosing specific drugs, whether for acute attacks or long-term prophylaxis. Headaches fall into two broad categories. Primary headaches are disorders in their own right and are typically episodic, with vascular and neuronal elements and often a genetic component. Secondary headaches arise from an underlying known cause, such as trauma, hypertension, infection, ENT or ocular problems, pregnancy, drug effects, or intracranial pathology. Distinguishing these categories early guides appropriate treatment. When evaluating a headache, always screen for red flags. Abrupt and severe onset could be a subarachnoid hemorrhage. Neurological deficits may point toward a mass or ischemia. Fever raises concern for meningitis. New onset after age 50 requires evaluation for temporal arteritis or space-occupying lesions such as cysts and tumors. Early morning headaches or those waking the patient may indicate raised intracranial pressure. Weight loss or histories of TB, HIV, or cancer also heighten suspicion for intracranial involvement or secondary lesions. A structured evaluation helps differentiate headache types. Assess pain quality, anatomical location, intensity, associated symptoms like nausea or photophobia, and timing. Migraine tends to be unilateral and throbbing with sensory sensitivity. Tension headaches are bilateral and band or pressure-like. Cluster headaches are severe, orbital, unilateral, and associated with autonomic features. Tension-type headaches present as mild to moderate, dull, aching pain described as a tight band around the head. Often, the patient would also complain of neck, scalp, and shoulder muscle pain and may have tenderness. Stress is the most frequent trigger. Management focuses on simple analgesics such as paracetamol and, in chronic cases, tricyclic antidepressants such as amitriptyline. Lifestyle counseling is an essential part of treatment, which should include sleep hygiene, stress reduction, posture, and hydration. Migraine is typically unilateral and throbbing, associated with nausea, vomiting, photophobia, and phonophobia. Some patients experience aura, which are transient neurological symptoms, while others do not. Its exact cause is not fully understood, but the current neurovascular theory places the trigeminal-vascular system at the center of the process. Migraine appears to originate in the hypothalamus, with downstream effects triggering the trigeminal-vascular system. Activation of the trigeminal nucleus caudalis, TNC, followed by peripheral release of pro-inflammatory calcitonin gene-related peptide, CGRP, most likely from C fibers, increasing intracellular CAMP and cGMP levels. Cyclic nucleotides bind with HCN or hyperpolarization-activated cyclic nucleotide-gated channels, depolarization and neuron firing and action potential, pain signal. The final effect is vasodilation and nociception, both mediated predominantly by CGRP. This diagram shows the same concept. Migraine appears to originate in the hypothalamus, with downstream effects triggering the trigeminal-vascular system. The final common pathway involves vasodilation and nociceptive activation mediated by CGRP. These insights have guided modern therapeutic targets, including triptans, ditans, and CGRP blockers. For acute attacks, when episodes occur less than 15 days per month, the goal is to abort the headache quickly. First-line agents include triptans, the newer lasmoditan, and ubrogepant, a CGRP receptor antagonist. Additionally, NSAIDs and paracetamol may be used alone or in combination, particularly for mild episodes, and antiemetics support patients with nausea. Triptans such as sumatriptan and zolmitriptan stimulate 5-HT1B/1D receptors. Presynaptically, this inhibits release of CGRP, and postsynaptically, it produces vasoconstriction. They are highly effective and well tolerated. Adverse effects may include tingling sensations, dizziness, muscle weakness, neck discomfort, and occasionally chest tightness. Sumatriptan is available in multiple formulations including oral, intranasal, subcutaneous, and rectal routes, making it versatile for rapid treatment. Lasmoditan selectively stimulates 5-HT1F receptors, providing migraine relief by suppressing CGRP release without causing vasoconstriction. This makes it useful in patients with cardiovascular risk factors who cannot use triptans. Side effects resemble those of triptans, but importantly, it does not cause angina. Its half-life is longer than most triptans, providing extended relief. Ubrogepant is a small molecule CGRP receptor antagonist used orally for acute migraine. It is well tolerated, with mild side effects such as nausea, fatigue, and dry mouth. Monoclonal antibodies are preventive agents, such as receptor-binding arenumab and the ligand-binding galcanezumab or fremanezumab. These are administered subcutaneously once monthly and are highly effective but expensive. Ergot alkaloids originate from Claviceps purpurea, a fungus grown on various crops, historically associated with ergotism, or St. Anthony's fire. This caused community outbreaks of hallucinations, gangrene, convulsions, and spontaneous abortions. Modern clinical use is limited to ergotamine and dihydroergotamine. Ergotamine acts as a 5-HT1D partial agonist and a 5-HT2 antagonist, also interacting with adrenergic and dopaminergic receptors. These mechanisms give it anti-migraine effects, but also significant toxicity. Adverse effects include severe nausea, vasospasm, uterine contractions, and possible abortion. Caffeine enhances ergotamine absorption, which is why they are sometimes co-formulated. For chronic migraine, defined as more than 15 days per month for at least 3 months, the objective includes prevention of such attacks. Evidence-based preventive drugs include propranolol, topiramate, gabapentin, and monoclonal antibodies targeting CGRP. Other agents such as verapamil, tricyclic antidepressants, and valproate may be useful in selected patients. Cluster headaches are extremely severe, unilateral, and typically localized around the eye or temple. They are accompanied by autonomic symptoms such as rhinorrhea, conjunctival injection, tearing, ptosis, or miosis. Clusters occur in cyclical patterns. Men and smokers have a higher incidence. Importantly, NSAIDs have no effect, and specific therapy is required. The indomethacin test helps distinguish cluster headache from hemicrania continua and paroxysmal hemicrania, which respond dramatically to indomethacin. Acute cluster headache treatment relies on 100% oxygen, which can rapidly abort an attack. Triptans, ergot alkaloids, and short courses of corticosteroids may also be used. Preventive agents include verapamil, which is the mainstay, anticonvulsants such as topiramate or divalproex, and galcanezumab, a monoclonal antibody targeting CGRP. These drugs reduce attack frequency and are essential in patients with recurrent clusters. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!